There are different causes for burns. The most commonly known one is exposure to heat. So this is, for example, when the person gets exposed to flames, hot liquids, or steam, like when someone, for example, opens a hot oven or dishwasher. Chemicals also can cause burns, something like solvents, cleaners, and alkali substances. Electricity can cause burns, and radiation such as sun exposure, like sunburn, and exposure to ultraviolet light. When someone experiences a burn, it's important to decide how serious the burn is. And there are several factors that we have to consider when we decide the seriousness of a burn. The first factor is the extent of the burn, and this includes the how large the affected surface area is. So this can be determined using what they call the rule of nines. Rule of nines is to divide the body into different areas, and every area is worth 9% of the body surface area. So you can see here for adults, for example, the head is 9%, the chest, the front of the chest is 9%, the abdomen is 9%, every leg is 9%, the front of the leg is 9%, every arm, front and back is 9%, and on the back, the top part of the back is 9%, the lower part of the back is 9%, the back of every leg is 9%, and there is 1% for the groin area. So do you have to memorize this? Well, it's called rule of nine, so um, it's not necessarily hard to memorize, but I'm not sure if you will need really to calculate the affected body surface area. But generally speaking, that's what we use. That's for adults. For children, we use the same rule of nine. It's slightly different. So because children have the head of a child is represents a bigger portion of the body. So the head in a children is 18%. The abdomen is 18%, and the back is 18%. This is similar to the adult. Every arm is 9%. So this is the front and back, both of them 9%. Same for adults. The only difference is the legs. So the legs in the children, the front is 7% for each leg, and the back is 7%, and the groin area is 1%. So this is again very similar to what we do with the adults. So we calculate based on the affected surface area and using the rule of nine to decide how large the affected surface area is. And also we have the same rule for infants. The next factor we consider is the depth of the burn. And the depth of the burn affects the healing time and the scarring. So here I will provide a description for the different degrees of burn, like first degree, second degree, and third degree. I don't know if you really have to memorize every single point about every kind of burn, because I think this is out of our scope as pharmacists. Other than having sunburn or something like that, I believe it's out of our scope. But anyway, I will provide some detailed description of everyone. So first we'll start with the first degree burn. So the first degree burn commonly happens after a very brief contact with a source of low intensity heat. Low intensity heat, something that's not extremely hot. It affects the epidermal layer. This is the outermost layer of the skin. And in the first degree burn, the skin appears red or pink due to the burn, and the skin blanches with pressure. What does it mean, blanches with pressure? This means when you put pressure on the affected area, the color will disappear. It will come back, but the color will disappear when you apply pressure. It's usually painful, of course, but this pain is usually at the beginning, and then it will start slowly disappear, and there may be also some edema. Patients who have first degree burn don't experience any blisters, so they don't have any blisters, and the first degree burn typically leaves no scars when it heals, and usually takes a few days to heal. The second burn we have is second degree burn, which involve the epidermis, which is the outermost layer of the skin, as well as the dermis, which is the second layer of the skin. If it only affects the upper layer of the dermis is the second layer. So if it affects the epidermis and the upper layer of the dermis, we call it superficial partial thickness. If it affects the deep layer of the dermis, so epidermis and the deep layer of the dermis, so it's a little bit deeper burn, and it causes damage to the hair follicle and the sweat glands, which is typically again exists deeper in the dermis. This is known as deep partial thickness. So we have two different second degree burns. We have the superficial partial thickness, and we have the deep partial thickness. So the second degree burns are commonly caused by scald. Scald is a spill or a splash of hot water or something like that. And this is usually superficial partial thickness. So if the splash happens because of hot water, someone, for example, is fixing some tea and the hot water gets on the skin, this can cause partial superficial partial thickness second degree burn. If it's a hot oil, so someone is cooking something and using hot oil, and this oil splashes on the skin, this can cause deep partial thickness, which is a second degree burn that involves the epidermis and deep layers of the dermis. Other causes can be exposure to direct flame, like exposure to heat, to fire, or to diluted chemicals. Diluted chemicals, concentrated chemicals will cause more serious burns. The difference between the superficial partial thickness and the deep partial thickness, we mentioned one difference already, that the superficial includes or involves the dermis and the upper layer of the epidermis. The deep partial thickness involves the epidermis and deeper layer of the dermis. So the differences between them, other than the layers of the skin that is affected, is pain. The superficial one is painful, while the deep one is painful only when there is pressure. So partial thickness, or the superficial partial thickness second degree burn, is painful. The deep partial thickness second degree burn is painful only when we apply pressure. Also, the appearance. The lesion itself, when there's a burn, in the superficial one, the lesion is moist, weeping, red, and it blanches with pressure, or it also may have small blisters. Okay, the deep one, the deep partial thickness burn, usually they are waxy and wet or even dry. So this is depending on how deep the burn is in terms of the dermis layer. The partial thickness, the deep partial thickness, also is red and blanches with pressure, or white. So that's white burn, so the skin is white. Both types, the superficial partial thickness and the deep partial thickness, both types can blister. In terms of healing, the superficial one heals within 10 to 21 days, and the skin color may change after healing. Generally, there is no long-term scarring. The deep partial thickness one needs more time, so typically needs more than 14 days to heal, and there is a risk of scarring or contracture. Contraction is when the skin starts to get tightening, is when the skin is tightening. So that's the second degree burn. This takes us to the third degree burn. The third degree burn involves the full thickness of the skin. So this involves the epidermis, dermis, and even can extend to reach the subcutaneous layer. The causes include exposure to a source of extensive heat, like being immersed in steam, direct flame, exposure to concentrated chemicals, or electricity. The lesion in the third degree burn is typically painless, and this is because of the damage to the nerves. So the nerves are damaged, so the patient doesn't feel any pain anymore. And the skin appears, or the lesion appears dry and waxy. This is because of the subcutaneous fat. So you can see the fat is melting and it makes the affected area looks waxy. The color can be anywhere from white to gray to even black, and the colors don't change with pressure. Patients may also experience fluid loss because when as you all know, the skin has important effect in keeping the moisture outside the body. So when there is a burn, especially if it affects large surface area, this will lead to evaporation of fluids from the underlying tissue. So this is something that the patient may experience. Third degree burns also never heal on their own, but interventions such as a surgery or graft surgery are needed. And the healing is associated with high risk of scarring and contractures. Finally, in terms of infections, the risk of infections increases with the degree of burn. So that's another thing that's associated with the degree of burn. So they change, or they differ from each other in terms of the affected layer, in terms of the appearance, in terms of the color, in terms of the healing, and also they differ according to the risk of infection. So superficial first degree burn, the risk of infection is low. The risk of infection gets higher with the second, and the highest with the third. Some references also will mention something called fourth degree burn, which involve the bone and muscles, and usually this kind of burn will result in the loss of the organ that's affected. Other factors to consider when determining the seriousness of a burn is the extent of exposure, and this refers to the temperature and the duration of exposure. The higher the temperature and the longer the duration of the exposure, the more serious the burn. Finally, we also have to consider body location, because this affects the skin type that's involved in the burn. So a burn that involves thin skin, such as the skin of the face or the skin of the eyelid or the skin of the ear, is more serious than a burn that affects thicker skin. Here we'll discuss the red flags that require referral to ER. So there are several red flags or symptoms. If they exist, we need to refer the patient to the ER immediately, not to the physician, to the ER. So these factors include, or these red flags include, any burn severity beyond mild superficial burn. So the one that has no blisters. So if the patient starts to have blisters, this will require referral to the ER. Any burn involving large surface area of the body, so this is defined as more than 10% of the total body surface area for an adult, or more than 5% of the total body surface area for a child. And as we discussed before, one way of measuring the extent of the burn is referred to as the rule of nines. Also, any burn that involves area of thin skin, we mentioned that before. One of the factors we consider when we decide the seriousness of the skin is the affected body part. And we said that some areas have thin skin, and this would be a more serious burn, and that this requires more attention. So that's why we refer any burn that involves an area of thin skin to the ER. So which areas are we talking about when thin skin is presumed? We're talking about face, ears, eyelids, inner surface of the arm, perineum region, and circumferential burn. Circumferential burn is a burn that goes around the body trunk. So it, like for example, it affects the abdomen and then it extends on the sides and reaches the back. Also, any burn affecting joints, even when blistering is minimal, this should be referred to the ER. Other groups that should be also referred to the ER is burns in children less than 5 years of age or adults older than 6 years of age, because these two groups are presumed to have thin skin. Also, any electrical, inhalation, or a chemical burn involving concentrated acid or alkali products, even if they appear to be minor, and that's important. So any electrical burn, inhalation burn, or a chemical burn that involves concentrated acid or alkali, even if they appear to be minor, they need to be referred to the ER. Why is that? First, because the injury may be deeper than the initial appearance. Second, it can progress to deeper tissue, and the tissue, the deeper tissue of the skin can be affected within 24 hours. So that initially it may look minor burn if it's electrical, inhalation, or a chemical burn, and the chemical burn here is specific to the ones that involve concentrated acid and alkali. We need to refer this patient to the ER, because even though the initial burn may appear minor, it may be more serious and it may continue to progress for 24 hours. Um, if there is a concomitant trauma, this is also a reason to refer the patient to the ER. So for example, electrical injury can cause cardiac arrhythmia, so we have to refer this patient to the ER. Finally, patients who are at risk of infections should be referred to the ER if they have a burn. So this includes patients less than 5 years of age and more than 60 years of age, diabetics, immunocompromised patients, alcohol abusers, malnourished patients, smokers, and patients with vascular diseases. Now we'll move to the management of burn. And the first thing we'll talk about is the goals of therapy. So we want to minimize further damage from the causative agent. We need to promote healing and restoration of the damaged tissue. We need to prevent infection and complications such as scarring and stricture. And also we would like to control the pain. Non-drug measures for burns. First thing we need to do is to stop the exposure by removing the contact with the causative agent or the source of the burn. So this will reduce further damage. For example, if the patient experiences chemical burn, we need to remove the soaked clothes and then irrigate the area using a large amount of running lukewarm water until the pH of the area is neutral. Generally speaking, alkali, if the patient is exposed to an alkali exposure requires longer time of irrigation. We also need to remove the burning clothes if the patient was exposed to direct flame, or to remove the electricity source if the patient is exposed to an or affected by electricity burn. We need to start cooling as soon as possible using cool tap water immersion. Immersion means you put the affected area in the tap in something that's full of tap water, or by compression. So you get some cloth and you soak it with water and then you apply this to the affected area. So we can do compression for 20 minutes, or we can do irrigation. So there are 3 different ways of cooling: immersion, compression, or irrigation. Irrigation is by keeping the area under running tap water for 20 to 30 minutes. And cooling is very, very important. Why? Because it reduces the severity of the injury, inflammation, and the pain. So it reduces the severity of the injury, the inflammation, and the pain. Important also to avoid ice. Many people, when they have a burn, they try to put ice on the burn. It's important to avoid ice. Why? Because ice can cause vasoconstriction and may worsen the injury, and actually it may also cause frostbite. Um, Also, it can cause hypothermia. So ice is not a good idea. Lukewarm water is the best. If the burn is serious enough and require further medical intervention, we need to transfer this patient to the ER, and we already discussed on a previous slide the red flags that require referral to the ER. During transportation to the ER, we need to continue cooling. We need to cover the area with cling plastic wrap. This is the one we use in the kitchen. This decreases water evaporation from the deeper skin tissue, prevent heat loss, and prevent infections. We also need to remove any restrictive objects. For example, if the patient has a watch, wearing a watch or a jewelry, we need to remove this stuff. Why? Because the affected area may swell, and this may become problematic because they can affect the circulation. We also need to clean the area using water and mild soap, and very important to keep the blisters intact, because if you open the blister, this can lead or increase the risk of infection. And we don't use antiseptics or disinfectant, just water and mild soap. And also, um, cleaning the area with water will clear any kind of secretions and will help removing any debris. If there are any blisters, keep them intact, as we mentioned before, because if you open the blisters, this will increase the risk of infection. If the blisters break, clean the area with water and mild soap. Finally, avoid using disinfectants or antiseptics to clean the area because they can impair wound healing. So don't try to use any kind of disinfectant to clean the area because this can impair the wound healing. So what we're going to do in the emergency room. Once the patient arrives to the emergency room, we need to assess the ABC. A is airway, B is breathing, and C is circulation, and assess whether there is a need for intubation. We need to establish an IV line if the affected surface area is more than 10% of the total body surface area. And we may need to start fluid resuscitation in patients with major burns. As we mentioned before, patients with major burns are exposed or are at risk of fluid loss due to the evaporation of water from the deeper tissue of the skin. So those who have major burn will need to have fluid replacement. And the needs in the first 24 hours are usually calculated using Parkland formula. So I provided Parkland formula here for you. So Parkland formula is 4 milliliter multiplied by the percentage of the affected body surface area, and this can be calculated using the rule of nines, multiplied by the weight in kilogram. So we calculate this amount. This amount is the fluid that the patient will need in the first 24 hours. 50% of the total volume is given in the first 8 hours, and then the remaining is given over 16 hours, and we need to adjust as needed. So for example, we need to monitor the urine output, and the children may require additional maintenance doses. We need to ensure urine output, and this is to ensure that the patient is not going through shock. Okay, so shock is when the vital organs are not getting enough blood. This can be due to hypovolemia or drop in the blood pressure or whatever. So we need to ensure that the patient is passing enough urine to make sure that the patient is not going through shock. And this may require bladder catheterization. In case of deep burn, we need to give a booster dose of tetanus vaccine if the patient had no doses in the last 10 years, and we may consider also giving tetanus immunoglobulin if the patient is not previously vaccinated. We need to do debridement by removing the loose tissue, but for sure we don't open intact blisters because this can increase the risk of infection, and we need to wash the area with sterile saline. Another thing we need to do in the emergency room is dressing. So the main goal of dressing is to maintain moisture in the skin and to prevent contamination and reduce the risk of infection. And there are different types of dressing techniques. Here we're talking about the techniques. We're not talking about the type of dressing. So the first one is what we call semi-closed dressing technique. This is when the area is covered with a layer of gauze, with or without antibiotic, and the dressing is usually changed once or twice daily. So we just cover the area with gauze. There is no necessarily taping the area or anything, just the area is covered with gauze. And they may use antibiotic on the affected area or not, and they usually change this once or twice daily. There is also what they call closed dressing technique. This is when the wound is covered with antibiotic and then covered with gauze, and then this gauze is taped in place. So it's kind of, you create a sterile area using the antibiotic to cover the burn. The open dressing technique, this is when the affected area remain open without any covering dressing, and the burn will dry up quickly. As this method, the burn will dry up quickly as quickly as possible, and this will allow the tissue to heal under a dry crust. So basically, the body will form a crust that covers the area, and we will keep the area dry and exposed to the air, so the body or the area will heal under the dry crust. The open dressing is usually used for burn on the head, neck, and perineum. Now we'll talk about the different types of dressing. On the previous slide, we talked about the dressing techniques. Now we are talking about the different types of dressing. So the selection of the type of dressing, whether it's a semi-synthetic or moisture retentive, depends on the amount of the exudate, the secretions. So the semi-synthetic dressing usually is changed every 7 to 14 days, or when the oxidates start to accumulate underneath. The other type is the moisture retentive dressing, which keep exudate away from the wound so that the wound can heal. So here is a list of the different types of dressing, and it depends on the amount of the exudate. So if there is no exudate, so for example, this is in superficial burn, we can just use wound pad, which is made of gauze, and this is considered a semi-synthetic. If there is minimal exudate, we use the um, hydrocolloidal dressing, and this kind of dressing facilitates debridement. It makes it easier to remove any kind of loose tissue, and this is also considered semi-synthetic. If the patient has light exudate, they use the polyurethane film, which is a semi-synthetic one. For patients with moderate exudate, so a little bit larger amount, here they start using the moisture retentive um, dressing. So we have for the moderate oxidate, they can use the hydrogel, which promotes faster healing. And they can also use the silver containing dressing, which requires less frequent changes, and it's also moisture retentive. For moderate to heavily exudating burn, they use the fiber dressing, and the fiber dressing has multiple benefits. Number one, it's less painful when it changes dressing, and number two, it can be washed off. So you can wash it off. You don't have to remove it. You can just wash it off, and this is also considered moisture retentive um, dressing. We have two other types of dressing. We have the biosynthetic skin substitute dressing. This is used for large area. And we have also the silicone coated nylon dressing, which is non-adherent layer used with other types. And the silicone coated one has advantages of it's non-adherent, as we mentioned, so it reduces tissue damage during dressing change, and that's why it's used with other types. When we talk about the pharmacological treatment of burn, we think of three areas: infection control, pain control, and itch control. Here on this slide, we will discuss the infection control. The first measure we will think about is topical antiseptics. However, topical antiseptics have limited evidence in preventing infection or promoting healing in patients with burns. The mainstay of infection control in patients with burns is topical antibiotics. Topical antibiotics are the mainstay to control infection in patients with burns. The agents we use are fusidic acid, mupirocin, bacitracin, and formycetine. And I'm sure some of you will ask and say, where is the silver sulfadiazine? We will talk about this in a second. Topical antibiotics are used to prevent secondary infections. And on a previous slide, we mentioned the factors that increase the risk of secondary infections, such as malnutrition, smoking, age less than 5 years of age, and more than 60 years of age, those who are immune compromised, and those with comorbidities such as diabetes and vascular diseases. When we use antibiotics, we need to apply them in a 2 millimeter thick layer, and typically they're applied twice daily. So it's important to keep in mind that we don't try to like rub the antibiotic in the skin. Topical antibiotics, we said that they are used to prevent secondary infection. However, we will not use them empirically on minor burns. So if the burn is minor, we will not use the topical antibiotic until the patient develops symptoms of infections. But if the burn is more serious, we will use them empirically to prevent secondary infections. Silver sulfadiazine, it's used to be a first line agent, but currently it's out of favor because it was found to be associated with poor healing. So we don't use it anymore. Oral antibiotics are not effective in preventing burn wound infection. Finally, honey. Honey has antibacterial and anti-inflammatory effect, and it promotes faster healing. And actually, applying honey to the wound, to the burn wound, was found to make the healing faster by 4 to 5 days compared to other conventional therapies. So the faster healing is about 4 to 5 days faster healing compared to other conventional therapies. The second domain we'll talk about in the pharmacological treatment is pain control. So pain is common in the first and second degree burn, and we already mentioned that before. And we need to monitor the pain daily during the management of the burn, and it should not be more than 5 on a scale from 0 to 10. What do we use for managing pain? First choice is analgesics. We can use acetaminophen and NSAIDs. These are commonly used measures, and NSAIDs, of course, reduce both pain and inflammation, and we avoid aspirin because of increased risk of bleeding. We can use oral or intravenous opioids for severe pain, but we will not use intramuscular or subcutaneous because of the vasoconstriction, which can reduce absorption. Topical anesthetics. Topical anesthetics have no evidence of relieving itch or pain. For topical anesthetics, we may consider using lidocaine or benzocaine, but these are associated with higher risk of sensitization. Pramoxine can be used if sensitization is a concern. So if we know that the patient develops sensitization when the patient uses lidocaine or benzocaine, we can use pramoxine. And pramoxine should not be applied to a large surface area. Generally speaking, when we use topical anesthetics, we should not apply them, even if we use lidocaine or benzocaine. We should not apply them to a large surface area because of the increased systemic absorption. The last domain of the pharmacological treatment is itch control, and itch is common during healing, particularly in patients with second-degree burn, and it should be monitored every 4 to 6 hours. We should monitor itch every 4 to 6 hours for the first 5 to 7 days. There are several agents that we can use to control itch. So we use menthol, camphor, and phenol. These are used as cooling agents and counter irritants. They help relieving itch, but they have no evidence. We can also use moisturizers. Moisturizers reduce itch in less severe burn, and they also reduce water loss and restore the skin barrier function. Skin barrier function is when the skin serves as a barrier that prevents water loss from deeper skin tissue. We can also use systemic antihistamines such as hydroxyzine and diphenhydramine, and they are used for more bothersome itch. Gabapentin has some evidence, and it can be used when moisturizers and antihistamines don't provide enough relief. We need to avoid topical antihistamines. This is important to keep in mind because of the increased risk of sensitization and contact dermatitis. We also need to use sunscreen, and sunscreen here is not used for the itch. Sunscreen is another measure that we need to use. So during healing, usually the burn area becomes sensitive to the sun, and this can cause further damage. If the patient is exposed to the sun, this can cause uh, further damage to the area. Plus, sun exposure can lead to hyperpigmentation. The sunscreen should be used until the area has completely healed, and usually we use sunscreen with a sun protection factor of 30 or higher. Another agent that we should keep in mind to avoid is aloe vera gel. Aloe vera gel has no clear evidence in burn. Plus, it can cause contact dermatitis, which will in turn increase itch. So it's not, or it should not be used to manage the itch.